Okay, so we're going to start out our chapter 55 lecture, the nursing care of patient with burns, going through our learning outcomes. So this is going to be explaining the pathophysiology of burns, describing the current therapeutic measures used for burns, listing data to collect when caring for the patient with burns, assisting with the planning of nursing care for patients with burns, and explain how you know if your nursing interventions will be effective. Alrighty, so chapter concepts, we're going to look at comfort, fluid and electrolyte self and tissue integrity. As the LPN, what are you going to do? You're going to apply the principles of infection control, provide non-pharmacological measures for pain relief, and perform wound care and dressing changes. Alrighty, so our pathophysiology of burns, this is going to be an energy transfer from one heat source to another. So this can be whenever our skin is exposed to something thermal, chemical, electrical, or a radiation source. This is that energy that is transferred to the tissues. So the amount of damage is going to depend on the temperature, duration of contact, and the type of energy source. Okay, so the heat denaturing these cellular proteins, the proteins in our skin and underlying tissues are going to begin to denature and coagulate whenever exposed to the high heat. So that's going to lead to the destruction of our cell integrity and lead to cell death and tissue necrosis. The interruption of blood supply, we're going to be looking about how burns damage the microcirculation, leading to vasoconstriction, thrombosis, and capillary leak. The result from this can be ischemia, edema, and further tissue destruction. Our severe burns can cause a systemic inflammatory response. It can be referred to as SIRS, SIRS, leading to burn shock, which is going to look like fluid shifts, hypovolemia, and electrolyte imbalances. Okay, so next is a picture. We have our zone of coagulation. Okay, so this is where we have that irreversible cell death. This is going to be the most severe area of the burn. The tissue is going to look like a whitish gray leathery appearance, and it's going to have no blanching. Okay, so this tissue is going to be permanently lost and requiring surgical intervention. The zone of stasis, so our middle dermal layer, where we have that stasis injury, this is going to be where our tissue is damaged but not dead. So it's going to be characterized by edema, vasoconstriction, sluggish blood flow. It's going to be fragile, but it can either recover or progress to a necrosis. Here, the appearance is going to be red, but still no blanching. This tissue or this zone, it can be salvageable, okay, with the proper treatment. Our very center layer there, our hyperemia, that's going to be our least affected area. So the vascularity is maintained. There's no permanent cell death, only minor inflammation. It's going to be red but blanch when pressed, and this zone can heal on its own within days or weeks. So think like with this very center layer, like your sunburned skin. So you can press on it, and whatever you release it, like it's red, you press on it, it blanches. Okay. So also just recognize that burns are not uniform. There's a spectrum of injury on this. Okay. I can't talk. So management is going to be aimed at preserving the stasis zone. So alteration in normal skin function, we're looking at the loss of the protective function. So our healthy skin, it's acting as a barrier, impaired temperature regulation. So as our skin normally is going to regulate our body temperature, with sweating, we can no longer maintain that balance. the risk for infection. Our skin is our body's first line defense against microbes, so that open burn wound creates a direct portal. Change in sensory function. Burns can destroy nerve endings, leading to the loss of sensation, so numbness or hypersensitivity. Moving on to fluid loss, burned skin loses its ability to retain fluids. Okay, so impaired skin regeneration, the loss of the epidermal skin cells is going to impair the natural wound healing. And the impaired, our impaired secretory and excretory function, so our sweat and sebaceous glands are going to be damaged. So this is going to affect our oil production in our skin, sweating, and any waste excretion. Okay. Alrighty, so the systemic response to burns, we're going to have that increased capillary permeability, so heat and inflammatory mediators are damaging the capillary walls, causing our vessels to become more leaky. Okay, the leakage of plasma and proteins, so the loss of albumin and proteins can worsen the edema, leading to third spacing, so that's where fluid is going to shift out of circulation and accumulate in our tissues. The loss of intravascular volume, so our circulating blood volume can fall dramatically, and this will lead to hemoconcentration, so thickened blood, okay? So whenever we have that volume going out, our blood is going to become thicker. Decreased cardiac output, so our low circulating volume is going to mean less preload, reducing the stroke volume and cardiac output. Volemic shock, that's going to be presenting as your hypotension, tachycardia, decreased urine output, possible altered mental status. Okay, so we're going to, when we get to that point, require aggressive fluid resuscitation. Decreased platelet function, so our platelets become less effective at clotting, so that's going to increase our risk of bleeding and impair our wound healing. And then the leukocyte and platelet aggregation, so the sludging effect is going to cause microvascular obstruction. Okay, so that's going to worsen our necrosis and tissue loss. Alrighty, continuing with the systemic response, so hypermetabolism and catabolism. So burns are going to trigger a massive stress response, okay, which so our resting energy expenditure is going to increase. So our patient enters a hypermetabolic state that can lead to our muscle breakdown, muscle wasting, and delayed healing. Okay, so this is going to require a pretty aggressive nutritional support. Negative nitrogen balance. I got a hair on me. Okay. So negative nitrogen balance, that means that the catabolism, so our muscle breakdown, is going to lead to protein breakdown, causing the loss of lean body mass. And our nitrogen is going to be lost through our urine. Okay. Hyperglycemia, so hyper with an E, from the stress response. Stress hormones like the cortisol and the catecholamines, they're going to cause insulin resistance. So you can have some pretty persistent hyperglycemia. Whenever our patients are hyperglycemic, it is harder to heal wounds. Okay, so we want to try to get as tight as glucose control as we can. GI complications. So that is going to look like reduced perfusion to our gut, the ileus, causing an ileus, ulcers, or GI bleeding. Okay, so we want to prevent this with our early enteral feedings, and then acid suppression, like our PPIs. So these people you're going to see usually a feeding tube placed. Renal insufficiency, so that's going to look like hypovolemia. That's going to lead to the decreased renal perfusion, giving us an acute kidney injury. And then our pulmonary damage. So it could be smoke inhalation, so airway edema, bronchospasm, the acute respiratory distress syndrome, ARDS, and then our hypoxemia requiring intubation and ventilatory support. And then our risk for infection, burn wounds are a breeding ground for bacteria. And so we want to combine that with some immunosuppression, and we just have a pretty hefty risk of sepsis that we're looking at, okay? So burns are going to affect every system is our overall point from these past two slides. So talking about the rule of nines. So our body is divided into regions. That's going to represent 9%, okay? The head and neck, that is going to be 9%. So the front is 4.5, back 5.5, or back 4.5 as well to make 9. Each arm is 9%. So front 4.5%, back 4.5%. Our legs are also the same way. Front is 9%, back is 9%. So each leg, if it's fully burned, can equal 18%. So front and back to equal the 18, and then front and back of your arm to equal 9. Alrighty, front of the trunk is going to be 18%, back of the trunk 18%, and then your perineum 1%. Okay, children have different body proportions. You can tell by the picture there. Head and neck 18%. Each arm is going to be 9%. Each leg 13.5%. Front of trunk 18%, back of trunk 18%, and then the perineum 1% again. And so doing an example of this, if the front of the trunk and one entire arm, so meaning front and back, are all burned, your total body surface area, you're going to have the 18%, okay, from the front of the trunk, and then 9% from the front and back, because front's going to be 4.5%, back's going to be 4.5%, making full 9%. So you'll have 18 plus 9, and that's going to give us 27%. Okay, this is used in an equation called the Parkland formula, and that is going to help us with fluid replacement calculation. So your Parkland formula is going to be, I really don't think you need to know the formula exactly, but just know that you use this using the proportion, your body proportion percentage, and that's going to help you calculate the fluid replacement calculation. Okay, so I could see like a test question for that, if there will be one, I don't know, giving you the formula, okay, and then you're using like the body percentage, you're finding the percentage to plug into that formula. That'd be a good math question. I'm gonna write that down. Okay, moving on to classification. So we have our partial thickness, our superficial burns, before they were referred to as first degree. This is going to involve only our epidermis. It's going to appear red, dry, it'll blanch with pressure, and there will be no blisters initially. Okay, so it can be painful and tender, but we can expect healing in 3 to 6 days with no scarring. Okay, so example of that would be a sunburn. A partial thickness deep, so that was referred to before as a second degree burn. That's going to involve our epidermis and then part of our dermis. It'll appear moist, blistered, a reddish pink, may look mottled. It's going to be very painful and hypersensitive to touch and to like air blowing on it. Healing, you can expect 2 to 3 weeks for superficial partial burns, and then more than 3 weeks for our deep partial. Okay, these can scar, Examples of this would be a scalding injury with blisters. Okay, I feel like I really contradicted myself. Okay, yeah, I did. Okay. So with our partial thickness, our superficial, I'm going to go back and check. Hang on. Okay, I did some consulting with my ATI book. So this is what I would go by for NCLEX purposes. So our superficial thickness, that is going to be damage only to the epidermis. Pink to red, no blisters, mild edema, no eschar. It's going to be painful and tender. It heals within 3 to 6 days. Okay, think your sunburn. Superficial partial thickness. So that's going to be damage to the entire epidermis and some layers of the dermis. Pink to red with blisters, mild to moderate edema, painful, heals within 2 to 3 weeks. So think brief contact with a hot object. A deep partial thickness, so this is going to be damage to the entire epidermis and deep into the dermis. So this is going to appear red to white. Blisters are going to be rare. Moderate edema, painful and sensitive to touch, healing in 2 to 6 weeks. Scarring likely, possible grafting needed. And that's going to be from your flame and scald injuries. So this is on page 529 of the Adult Med Surg book. Okay. And then moving on to the full thickness, this was once the 3rd degree burns. So this is going to be damage to the entire epidermis and dermis that extends into the cutaneous tissue. We're going to have nerve damage here, severe edema. It can appear red, black, brown, white, yellowish, no blisters. The eschar is going to harden, be inelastic, and then you're going to have minimal sensation with this, okay? This is going to take weeks to months. There's going to be scarring, possible grafting needed. This is going to be from scalding injuries, grease, tar, chemicals, electrical burns, and prolonged exposures to hot objects. So our deep full thickness burn is going to be damage to all layers of the skin that extends to the muscle, tendons, and bones. It'll appear black with no blisters, no edema. The eschar will be hardened and elastic. No pain with these burns, heals within weeks to months, scarring expected, grafting expected, and this is going to be your high voltage or prolonged electrical burns or with direct flames. Your ATI book, that 529, has a nice picture, if I can get it together, picture and graph. Okay, so check that out to look at the classification. That's really good. Alrighty, so next we have a couple pictures. Just looking at these, so we have a partial thickness burn. Here I want to point out we have the redness, obviously the large blisters. It's moist, shiny, has irregular borders. Okay, so these kind of burns, they're going to be painful. The superficial partial thickness will heal in about 2 to 3 weeks with minimal scarring. So if you see blisters plus redness and looks moist, think partial thickness. If your burn looks more white, leathery, you're moving on to the full thickness, okay? Alrighty, next we have a partial thickness burn. This is going to be more of a so it's hard to tell with this picture, but to me it looks more like areas like this of the white leathery where it's came away. So they have it classified as the partial thickness. The white leathery, that's more of our full thickness, okay? So maybe they're trying to get at, like, I'm not sure what they're going with here, okay? So it's just providing a good contrast, I guess, but it would be better in color. I don't like that picture, so we're going to skip it. Okay, a full thickness burn. This is a good one. So here I want you to observe, we have the charred areas there. Okay, that's going to be our eschar formation. Our white leathery tissue, where my mouse still is. So that's going to be where we have that coagulation necrosis going on. We also have pink and red patches, so we have deep partial thickness burns. We have the dry appearance on some of them for the typical full thickness burn, that dry tissue sloughing. So with this, also observe their toes here. Looks like we have some circulatory compromise here, some ischemia. Okay, so this is a good picture of kind of a mixture of a lot of different burns. Okay, so just be aware that often these burns can all happen together. Okay, we can have different burns on the same limb. Okay, so etiology of burns, we have flames, example, house fire, wildfire exposure, clothing catching on fire. Okay, contact burns is when our skin touches a hot object. So examples of this is going to be like grabbing a hot curling iron or straightener. An example they gave was a child touching a space heater. Okay. Scalding, for example, from hot liquids. So spilling your coffee on you, steam burns from opening like, I don't know, your Instapot or whatever. Bath water that can be too hot. This is common in your pediatric population. Chemical burns, so that could be just from your household cleaners, agriculture chemicals, so like fertilizer, pesticides. Electrical burns, so when we have current going from passing through the body, so this will be often with internal injury. Okay, so this could be contact with our power lines, inserting an object into an electrical outlet, or a lightning strike. Radiation burns are going to be caused by prolonged exposure to radiation, so this could be burns from radiation therapy, like for cancer, our UV radiation, sunburns, or it could be a workplace exposure, like X-ray overexposure, nuclear accidents. Okay, I do have a table set up. I want to call it a table. It's a Word document that's under your burns section. Okay, and it kind of breaks down each of the diagnostic tests. Okay, so I'll leave you to look at that one, but that's there, and that's the information you need to know. So just nitty gritty, what it is, what the purpose is, what it's telling you. Okay, so therapeutic interventions for our major burns, looking at going back to our like disaster type stuff. So in our primary or emergent stage, we're going to assess our ABCs, okay, looking for an open airway. What is their breathing looking like? Okay, assessing their circulation. We want to, of course, stop the burning process if that is still in process. Stabilize any related injuries. Our IV fluids, we are going to look at that with that Parkland formula. So looking at the body surface area and finding the percentage of what is burned, and then also control pain if needed. Okay, I skipped a little too far. Well, I don't know how to go back. Okay, so that next slide, I can't go back, was talking about the acute stage. So in the acute stage, we need to clean and debride the wound and dress it as needed, prevent infection. They'll determine if this patient needs skin grafting, control their pain, and maintain a nutrition and fluid electrolyte balance. Okay. Next, we have several activities. Excuse me. Nope. I can't go back. Okay. So what it talked about, though, was our skin grafts. Okay. Okay, I have tried to go back to the skin graft, and it will not let me. So I will explain it, and we'll go from there. Okay, so for our skin graft, your book mentions the autograft. So that's whenever we're taking the person's own skin from a donor site on themselves. So let's say I have a burn on my arm, so I need to cover this area, so I can have part of my thigh. That's a common place to take an autograft from. So we'll take, we can either do a sheet graft or a mesh graft. So with the sheet graft, we are just simply taking a sheet of this person's own skin, and then with a mesh graft, we're putting it, so with a mesher, you're having like small slits put in it, that way it can stretch over and cover a larger area. Okay, but it focuses on a split thickness graft, so this is where we're taking the epidermis and part of the dermis from that donor site and placing it. So this can cover large wounds, burns, or chronic ulcers. An advantage of this, it has a higher chance of survival. Okay, our donor site heals faster. And then for our full thickness graft, the layers taken are the entire epidermis and the full dermis. This has to be surgically sutured. Since it's thicker, it's going to be a better cosmetic appearance. Okay, so the advantage is it's more durable, and it has a better long-term cosmetic result. Disadvantages is it needs a good vascular wound bed to survive on, so it has a less likely, you have a poor, I don't know how I want to put this, gosh, it's resistant to surviving, we'll say that. Okay, so in short, your split thickness is going to be thinner, you have larger coverage, you have faster healing at that donor site, but it is more fragile since it is thinner. The full thickness, it's going to be thicker, stronger, a better cosmetic match, but it's limited to a smaller area. Okay, so moving on to this picture right here, the escharotomy. So this is a surgical procedure when you're only making incisions through the burned area, so the eschar, to relieve pressure and restore circulation. So this is similar to a fasciotomy, only you're going through that layer of eschar. Okay, so this is going to be to relieve pressure. It can be done at the bedside. Indications we would do this in is whenever we have absent or diminished distal pulses, increased pain and numbness, cool or pale extremities despite the resuscitation, compartment-like syndromes, okay? Or if we have restricted, if we have burns on the chest, if we have restricted chest movement, which is decreasing our oxygenation, okay? So this can be done at the bedside or in an OR. We want to have it under sterile conditions and just along the length of that eschar, okay? So we'll move on to our rehabilitation stage. So for our reconstructive therapy, that's going to be for our burns that lead to deformities and impair our function, our activities of daily living, okay, or if it's just for simply a cosmetic concern. So our reconstructive surgeries may involve like a scar release, skin graft revision, flap coverage. They're often done in stages though, okay? So our goal with the reconstructive surgery is not always cosmetic, it's also to restore function and improve mobility. We want to prevent contractures. Physical therapy helps us with this so that the scar tissue tends to shorten and tighten, and that will lead to a contracture. So we may need to position to avoid certain planes of motion. So we want to do a consistent range of motion with this patient, so that our consistent range of motion would go on our early prevention. Okay. With using physical therapy, we are going to help preserve the muscle mass that we have, improve joint flexibility, prevent atrophy and stiffness. Okay, so this may involve physical therapy using assistive devices or compression garments. Occupational therapy can come in and help with fine motor skills to help preserve this person's independence. And then the psychosocial care, many of these patients struggle with PTSD, depression, and anxiety. Their altered body image and self-esteem is affected. So we want to encourage them to seek support groups and counseling. Okay. So our overall goal in rehabilitation is going to be to holistically help this patient. Okay. So blending surgical, physical therapy, occupational therapy, contracture prevention, and psychosocial support. Alrighty, here we have a picture of a contracture, and that's going to happen from that permanent tightening of the skin and muscles and tendons as they occur. So the burn is going to, or our burn scars, they lack that elasticity of normal skin. So as they start to get older, they'll pull more. Okay, we want to prevent this, excuse me, to prevent loss of functional mobility. Alrighty, for the rest of our lecture, we have our lecture slides. We have several nursing diagnosis, as well as a case study to look at, a SBAR. So if you have any questions about those, or the review questions at the end, why they were answered the way that they were, we can talk about those in class. So just make sure that you bring those questions with you. Okay, and as always, reach out if you have any questions.